The results of the 2024 U.S. elections could affect health policy in important ways. The next president and Congress will have to make decisions that have implications for insurance coverage and access to health care, affordability of health care, and health equity, among other issues. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Jose Figueroa, an associate professor of health policy and management at the Harvard T.H. Chan School of Public Health and an assistant professor of medicine at Harvard Medical School. The journal recently published 3 perspective articles about the U.S. elections and health policy in conjunction with a symposium we co-hosted with Dr. Figueroa's department at the School of Public Health. Dr. Figueroa, how could the outcomes of the elections affect insurance coverage, including enrollment in the Affordable Care Act marketplaces and in Medicaid?
Access is going to be a major issue in the next election. If we were to look back and ask one important question, what proportion of the population does not have healthcare insurance in our country? Before the Affordable Care Act was passed, it was about 16% of the population. Since then, because of the passage of the ACA and other provisions during the COVID pandemic, uninsurance rate has dropped dramatically to about 8% now in 2024. And there's 2 big reasons that this insurance rate is record low in the history of our country. Number 1 is Medicaid expansion, and number 2 is the creation of the ACA health insurance marketplace, or the ACA exchanges. And again, these were 2 big efforts that led to a lot of new people getting insured, about 45 million people insured. Now, 2 issues related to the upcoming election that directly affects these newly insured populations are that there are going to be expirations of subsidies that allowed more people to enroll into insurance coverage. Number 1 is the American Rescue Plan of 2021 and also the Inflation Reduction Act of 2022, which boosted enrollment into the marketplaces by giving more premium subsidies to people who are low income but not so poor to qualify for Medicaid. And there are concerns that with these extra subsidies that are set to expire by 2025, the end of 2025, that many people will lose the newly gained coverage that they had under the provisions. And so depending on the next Congress and the next president, there's going to have to be a decision made about whether or not to extend these subsidies, keep more people insured, for example, in the marketplaces, or whether we're going to let them expire. Vice President Harris has indicated that she will likely extend the subsidies within the first 100 days of being elected, whereas former President Donald Trump has not indicated, although there are some of his advisors that have suggested that we should not extend some of these subsidies. So that's a major issue on access. The other thing that's really important to note when it comes to access related to Medicaid expansion is that not all states in our country decided to expand Medicaid, and that was because expansion was made optional from the Supreme Court decision in 2012. Today, 10 states have not expanded Medicaid, and that means that there's about 3.5 million people in these states that if they expanded, they would immediately get access to Medicaid. The majority of these states are in the South, where there's a high proportion of people who are Black and Hispanic. And unfortunately, that means that about 2/3 of the people in this gap are people of color. And I think historically, Vice President Harris has been supportive of Medicaid expansion and encouraging local, state, and legislative efforts to help states expand Medicaid. Whereas on the Republican side, specifically Donald Trump's side, there's been less support for Medicaid expansion. And there's interest in actually including things like Medicaid work requirements, which is a requirement for people that if you want to get Medicaid, you have to show proof that you're at least trying to look for a job. Historically, the data suggests that Medicaid work requirements do not work in helping people find employment. Instead, they just introduce administrative barriers, administrative hassles to keep people who qualify for Medicaid from enrolling into Medicaid. And so there's concerns that introduction of Medicaid work requirements will actually be bad for low-income people.
And then what about Medicare? How are Medicare policies, including approaches to the Medicare Advantage program, likely to vary depending on whether Republicans or Democrats control the White House and Congress?
One thing that's very clear is that Medicare is very, very popular among seniors specifically. And we know it is very important because for any candidate to think about and talk about Medicare because seniors vote. One thing to think about when it comes to the Medicare program is that it has been rapidly changing over time because of the growth of Medicare Advantage. Right now, every person who qualifies for Medicare has two options. They could either choose to enroll in traditional Medicare or Medicare Advantage, where they enroll with a private plan. The big difference between the two is in traditional Medicare, you basically have flexibility to almost see any provider you want and get care at any hospital you want, but it is not cheap. Medicare is not free. There's a lot of cost sharing that every beneficiary that enrolls incurs. And one major concern in the traditional Medicare side is that there's high cost sharing for many, many services, including for hospital care and getting care out in the outpatient setting. And then the other thing is that if you are in traditional Medicare, you don't have supplemental benefits like access to hearing services, dental, vision services. And so those are big issues, especially for people that have limited incomes and who might require, as you can imagine, as we age, services related to helping us hear better, see better. And then the other thing that's really important with the traditional Medicare is a lot of people have to go out and buy extra insurance, which we call Medigap plans. And that's to help them protect themselves from incurring really high out-of-pocket spending in case they get really sick, because there is no out-of-pocket caps in the traditional Medicare program. So now enter Medicare Advantage. Medicare Advantage is the alternative option by managed care companies, private insurance companies. And if you choose to enroll in Medicare Advantage as a beneficiary, it comes at a price. The first thing is in the form of narrow networks. You cannot go out and see anyone you want. And the second big issue is that there's often a lot of gatekeeping that occurs when you're trying to get care. There's a lot of utilization management, prior authorizations at play that sort of try to keep you from using care if the insurance plan thinks that the care might not be necessary. It also protects people for out-of-pocket caps, or there's some financial protections. So you don't need to go out and buy a Medigap plan if you're in the Medicare Advantage. And then also gives you supplemental benefits. A lot of Medicare Advantage plans are offering extra benefits, including dental, vision, hearing, and for certain select people with certain chronic conditions, you get even things like food services, like meals, transportation services, things like that. The big issue, especially as Medicare Advantage is growing, with now in 2024 into 2025, about 53 to 55% of all Medicare enrollees in Medicare Advantage now, is that Medicare Advantage is very expensive to run. It's estimated that CMS, so taxpayers, pay for every person that chooses to enroll in Medicare Advantage, they pay about 20% more in costs than if that person would have remained in traditional Medicare. And so as more and more people are enrolling in Medicare Advantage, we're paying a lot more and more for people. And the reason why MA is expensive to run is because insurers keep some of the money that's paid as premiums as profits to run the program. That's number one. Number two, there's a lot of concerns that we overpay MA plans as a country because they engage in really aggressive risk capture or upcoding. And one main issue is that the payments are based off of traditional Medicare populations, where there is not such as an aggressive risk capture activity happening. And then there's also issues with some of the bonus systems that we pay MA plans a lot of money in bonuses based on not so perfect quality measures that have issues that could be gameable. And so this is a major issue. And so looking forward, one thing that is challenging is that neither candidate has really expressed any desire to reform the Medicare system. Again, no one wants to completely overturn it. I don't think that would be very wise from a voter's perspective, because again, it is a popular program. But affordability is a major issue. And so then the big question is, how do we reform the Medicare system? What would candidates want to do to make it a little bit better? And there's a lot of ideas out there. One idea is to fix the traditional Medicare program. There was a recent paper by Dr. Michael McWilliams offering ideas of how you could make traditional Medicare more competitive. For example, making it match what Medicare Advantage currently does, introducing out-of-pocket caps, offering supplemental benefits. There's no real issue of fixing an overpayment for upcoding in traditional Medicare. And if you make traditional Medicare much more competitive, maybe people are going to choose traditional Medicare, which again is costing about 20% less per person that enrolls in traditional Medicare than they would in Medicare Advantage. Other things that I think are really at play, and we're seeing CMS increase their activity in terms of regulating how MA plans are being paid. They're trying to fix issues of overpayment related to upcoding or aggressive risk capture. They're trying to figure out how to sort of adjust the formula based on benchmarks. And one thing that I think is really interesting and more attention should be put into this area is ensuring profiteering is minimized in Medicare Advantage. There's a concern that there's a lot of profiteering behavior occurring among MA plans where they're keeping a lot of profits and they're not necessarily passing through benefits that are purportedly being passed through. So for example, there are concerns that these supplemental benefits like the dental and the vision and the hearing and the meal plans, some of them could be actually ghost benefits, meaning they're being offered, but people actually don't use them, or it's really unclear for how patients can get access to them. And CMS is requiring plans to be much more transparent and informing patients which benefits they are eligible for. And if they're not using them, reminding them that they have access to them. And so that's some activity that I think would be interesting to watch depending on who the next president is.
So another aspect of affordability involves prescription drugs. What steps do you think either a Republican or a Democratic controlled government would take to address drug prices?
Healthcare affordability specifically to drug prices is in some polling data recently conducted by Dr. Bob Blendon, who I believe you also feature a piece on this, is the biggest issue related to healthcare for the American people. And one thing to think about is that there's a reason why we have really high drug prices in the United States, and it's a trade-off that we've been currently dealing with for many, many years. High prices in the drug market are primarily driven by market power from patents that are given to companies, which effectively give them temporary monopolies. And that kind of system really incentivizes high-risk innovation and investments. And we arguably have seen a lot of advancements in the areas, for example, of anti-obesity medications, cell and gene therapy that are really revolutionizing the way we treat people. And in many cases, curing people from diabetes, obesity, and other diseases. But the big issue is that this system also unfortunately leads again to really high drug prices that are not sustainable in the long run. And as these new classes proliferate, and more people are eligible to take them, it really asks the question, how as a country are we going to afford them? Some of these new therapies that are, again, revolutionary for conditions that have been historically very hard to treat are going to potentially be breaking budgets left and right, including employer-sponsored insurance budgets, state budgets like Medicaid budgets, and the federal budget, Medicare. And there's a real problem about how do we sort of keep our ability to afford these new therapies and existing therapies, all of the other medications that we're already taking that have been discovered and been in the market for many, many years. How do we afford everything? And so this is where I think is really interesting, where both candidates have suggested that they are interested in dealing with issues of drug affordability, both the Trump administration as well as Vice President and the Biden administration. The issue is how exactly they're going to go about doing this. How aggressive are they going to go about doing this? We do have one example right now that will be really interesting to watch. And depending on the next president, we might see more of this type of activity or potentially less. And that's through the Inflation Reduction Act. First thing I'll say is that this is really only affecting Medicare. It is not affecting commercial drug prices. But the hope is that if Medicare drug prices, that a lot of other insurance plans based how much they pay on Medicare. And so what is the Inflation Reduction Act? What does it do? The first thing is it's all about addressing issues of drug affordability in the Medicare for Medicare beneficiaries. It gives subsidies to low-income people to be able to afford drugs. The second thing is that it introduces caps on out-of-pocket spending, so trying to protect people from going bankrupt and being able to afford and take their medications. And then the big thing is, for the first time ever, it is allowing Medicare to negotiate drug prices for a specific set of drugs that meet certain criteria. The criteria is they have to be in the market for a certain period of time, and also it has to be among the highest grossing drugs, that meaning the drugs that are most expensive from the Medicare perspective in terms of the unit time price. And I think the jury is still out about whether this policy is going to work. And I think for both candidates, it's a little bit of a wait and see about what happens next year and in the years that follow, because over time, CMS is going to be able to negotiate more and more drugs. And depending on what we see in terms of how it impacts the market, how it impacts prices, how not just of Medicare, but other insurers in the commercial market and in Medicaid, I think we'll then see what would come next and whether we need to do more of this type of policy or potentially be needing to change it.
And then finally, policies related to health equity could also be affected by the results of the elections. What do you see as the most important health equity challenges that are currently facing the country, and what would the current candidates do to address them?
So as you know, and we all know, health equity is a major issue in our country. Many people in our country suffer from significant health inequities, specifically low-income populations and minorities, people of color. And these disparities manifest in many ways: unequal access to healthcare, higher burden of chronic diseases, poorer health outcomes, and really concerningly shorter life expectancy. In the symposium, and one of the perspectives will highlight about how Black people, Native American people are much more likely to die related to guns, firearm deaths, more overdose deaths among people with lower educational attainment, obesity prevalence being much higher among low-income populations, and then Black people, for example, being much more likely to die during pregnancy or during delivery. And then the other thing, as we know, is that the COVID-19 pandemic, anytime there's a shock to the system, we are painfully reminded that the most socially vulnerable in our country are the first to suffer and die. And part of the symposium and one of the perspectives highlights what is behind many of these health disparities in our country today, and then importantly, what matters in this election and any election, both past, present, and future. And that is around issues related to structural discrimination. So what is structural discrimination? It is defined by one of the panelists as the ways that laws, policies, and practices are used to structure mutually reinforcing systems, whether it be the housing sector, healthcare, education, public safety, in a discriminatory way that tends to advantage one group of people and disadvantage other groups of people. And there was an example that was brought up in the symposium, and it's discussed in the perspective, is that obviously all elections matter. And one reason is because the president appoints people to lead agencies like CMS, CDC, the FDA, HHS, and importantly, federal judges with lifetime appointments. And recently, this summer, that matters so much more than ever before in the last 40 years because of one decision by the Supreme Court. And that was the overturning of something called the Chevron doctrine that had been in existence for 40 years. And it was overturned by a majority conservative Supreme Court. Why does that matter? The doctrine is a doctrine that gave deference to the expertise of agencies like the CDC, like CMS, like the FDA, to interpret ambiguous language in laws pertaining to issues specifically to their work. And so anytime there was a law that was not clear exactly how to interpret it, agencies had a lot of power to sort of move forward with what they thought was in the best interest of their patients, for example, in the case of CMS. And that's how business was done for the last 40 years. And with that overturning, it basically took away the power away from agencies and now instead lies with federal judges. And so there's substantial concern now that there's going to be a lot of decision-making across our country by federal judges that have lifetime appointments that are put into power by the president often and the president's administration, who might be making really important decisions that can have national impact, but they might not necessarily have the qualifications or the expertise to be passing judgment. And that's why 40 years ago, the decision was made to allow the agencies to be able to make more of those decisions. And that, I think there's a lot of concern that there's going to be a lot of complexity and chaos into decision policy making and rule making and regulation making across the country. And again, it's going to depend on who is put into that judge's seat. And again, the election would matter. And then the one last thing I'll say about why elections matter, specifically with regards to health equity, is that one thing is very, very clear. And that is low income and minoritized populations, including Black and Hispanic or Latino people, are less likely to vote. This has been called as the biggest political determinant of health that determines so much of our daily lives in our country. The views of people of color and the views of low-income marginalized communities are often not represented in local, state, and federal government because they don't vote. And ultimately, the decisions of, for example, whether or not to expand Medicaid in the remaining 10 states that are holding out are left to people who are put into office that don't necessarily reflect their views. And one thing that's really important that in our country, if we want health equity to be improved, is that we have to figure out how to give voice to so many people who are living in poverty, living in marginalized communities and minoritized communities to get their views and their preferences and their needs represented across all levels of government.
Thank you, Dr. Figueroa.